So thank everybody for coming. I'd like to start by acknowledging the country and pay our respects to the Ngunnawal people and their elders past and present. I'm Bob Wells. I'm the director of the Australian Primary Healthcare Research Institute, which is based here at the ANU and is funded by a grant from the Australian Government Department of Health and Ageing to undertake and commission research in primary healthcare. As part of our program, we have a visiting fellowship scheme of eminent people sponsored to come to Australia, and tonight we have the honour of having Professor David Weller, who is actually an Australian, but has been in England and Scotland, but is now at the University of Edinburgh, where he holds the Mackenzie's Chair of General Practice at the University of Edinburgh. And David also leads the Cancer and Primary Care International Research Network. David's particular interest is in cancer research and cancer management in primary healthcare, and he's going to talk to us about that tonight. So thank you all for coming. David will talk, then we'll have time for questions and discussion, and then following that there'll be refreshments served in the foyer outside here for further discussion if that's needed. So David, I'll hand over to you. Thank you.
Thanks very much, Bob, and thanks indeed to the Australian Primary Healthcare Research Institute for giving me this opportunity to spend some time in Australia and do some talks, meet some interesting people, escape the Edinburgh weather, and come to this. It's still a little bit wet from walking about 20 metres here into a lecture theatre. As Bob said, I wanted to share some ideas with you about the role of primary care in cancer control. By cancer control, I'm talking about everything from early prevention to screening to management and survivorship. We'll touch on a couple of palliative care issues as well. So, here we go. First of all, I wanted to have a bit of a discussion about why we should consider primary care when it comes to improving our outcomes in cancer in countries such as Australia and the UK. And probably most of you won't need convincing of this, but just in case, primary care is generally considered to be central to a lot of the reforms that are happening internationally. It's increasingly recognised, I think, that health systems with well-developed primary care tend to have better health outcomes. One of the sort of gurus of primary care academia was a woman called Barbara Starfield, and she did some excellent work linking the extent of development of primary care with a whole range of favourable health outcomes. And there's, I think it's also fair to say, an international trend towards more primary care-based services, primary care-based management of chronic diseases, away from hospital-based services, not just because primary care can deliver that management more cheaply, but also there's a growing body of evidence, some of which I'll allude to shortly, which suggests that primary care can produce equal or better health outcomes. And there's a lot of interest, as I said, internationally. The WHO has got a renewed interest now in promoting primary care, both in developing and wealthy countries. So it seems to make sense that if we're considering how we can do better with cancer, that primary care should be at the centre of some of those considerations. And here are some key features of primary care, again, which you'll be probably largely familiar with, but it's considered to be directly accessible, first point of contact. In primary care, we see unselected health problems. It offers the whole gamut of healthcare services, whether it's preventive, diagnostic, curative or palliative. It's all within the remit of primary care. A holistic approach, one in which factors such as comorbidities and psychosocial problems can be addressed. It has a key role in the management of multimorbidity or comorbidity, and it has this emphasis on coordination and continuity of care. And when we're talking about patients with cancer, often their needs are quite complex, and they need to be dealt with in an environment where that kind of coordination and continuity of care can be offered. So here is a kind of diagram of the cancer journey, if you like, and what I hope to convince you of in the next 25 minutes or so is that primary care has a key role in each of those stages of the cancer journey, right from prevention up to follow-up and end-of-life care. These are some data from Scotland, where I'm currently based, but they would be reflected in other Western countries, and they really just underline the extent of multimorbidity in our ageing population. We can no longer think of single disease entities. We need to think of people with chronic illnesses as people having perhaps one major condition and two or three other conditions as well. And this graph just represents how that the extent of multimorbidity grows with an ageing population. And of course, cancer is a disease which the patient population is also growing older and older. So increasingly, we're looking after patients in this sort of age group, from 65 onwards, and we'll be needing to look after this range of comorbidities. They might have hypertension or osteoarthritis or respiratory disease. So looking at cancer in isolation is increasingly unhelpful, as it is for any chronic disease. These are some data which I've shown a couple of times today already, so apologies to people who've already seen it. But it really just compares survival data for 4 common cancers, makes comparisons between different countries, and Australia is represented there. Those data come from New South Wales and Victoria. Now, countries such as Australia and Sweden, which are the blue and green lines on these graphs, typically do pretty well in both 1 year and 5 year survival. And that is repeated really for all of those 4 cancers. So it suggests that in Australia something is working for some reason or other. The survival data are pretty good. Of course, these data are less encouraging for countries such as the UK and Denmark, and it's caused a lot of head scratching as to why these, on the surface, comparable countries aren't doing so well. It's quite substantially lower survival rates for these common cancers. And of course, a number of hypotheses have been put forward. It may be differences in availability of treatments, although those aren't obvious on the surface. Is it differences in screening rates for cancers? Is it lower awareness of symptoms? Is it the fact that people present later with their cancers in countries such as England? We still don't really have firm answers to those questions. But one question which is prompting a lot of interest is the role of primary care. How does primary care respond to patients with symptoms of cancer? Do we effectively recognise symptoms? Do we make proper and appropriate referrals, and so forth? And one element which I'm involved in this big international exercise is looking at that journey within primary care. Unfortunately, this is ongoing work which we don't have the results of yet. So let's just quickly whiz through that cancer journey, and beginning with primary prevention. And if one looks at the key risk factors for the common cancers, smoking, alcohol, physical activity, on the whole, there is quite a lot that primary care can do. There's been years of accumulated evidence, for example, around smoking, that even brief interventions from GPs can bring about quite substantial quit rates. You have to give that advice to quite a few people, but nevertheless, it has proven effectiveness. Similarly with alcohol, again supported by randomised controlled trials, Cochrane systematic reviews, brief interventions from GPs and primary care teams can bring about reductions in alcohol consumption. For diet and obesity, the evidence is more mixed, but particularly for high-risk patients, where we're talking about fairly moderate to high intensity interventions, there's again some evidence, some quite good evidence that primary care-based strategies can make a difference. And if we look at what sort of things primary care organisations such as Medicare Locals might be able to do in terms of supporting this primary prevention, and we had some discussions about this afternoon in a policy forum. They sort of include activities such as brokering referral services to support behaviour change, ensuring quality and standards, and coming up with processes of monitoring and performance improvement. And this is, I think, a potential quite significant role for these for new primary care organisations as they evolve around the world. Because there's no doubt that lots needs to be done. Australians visit their GP frequently. They want to receive preventive information. We know that from numerous surveys in Australia, and yet very few encounters in Australian primary care actually involve risk factor assessment and intervention. So these are just some data which show the high rate of consultations with potential to do something about those important primary risk factors, not just for cancer but for cardiovascular disease and a range of other chronic illnesses. And these are some figures about what actually happens. And there is, I think, quite a good case to be made that even though we know primary care can make a difference with these risk factors, that more could be done. And Underpinning all of this in Australia is some excellent guidance for preventive activities in general practice, and it's really important to have guidelines like this so that GPs and organisations such as Medicare Locals have got a good reference point to refer to and a good sort of solid source of evidence. So that's a quick overview of primary prevention. The role of primary care in screening, in cancer screening, it varies a lot. If we think back to the early days of cervical screening, it was largely left up to GPs to do screening in a fairly opportunistic way. There was no central state-run or federal-run program in this country or indeed in other countries. That has tended to change over the years, but if one looks at the sorts of roles that primary care can have, yes, it can get involved still in identification and recruitment of participants. If you look at the way that screening is organised in North America, a lot of screening is primary care based, is office based, opportunistic screening in which doctors, primary care doctors, are responsible for that, for actually getting people into the testing process. They can, of course, provide the testing. A lot of doctors, a lot of primary care practices anyway, still provide screening such as cervical screening, and they can get involved in the coordination of follow-up. For example, bowel cancer screening in this country, whilst there are centralised processes for recruitment and providing the test, it's still up to GPs to follow up those tests and arrange appropriate referrals and investigations. They can also have complementary roles, as I said, with centralised programs, perhaps sharing of some of these tasks, but they can also endorse screening invitations, and we have good evidence now that good primary care engagement in cancer screening programs actually leads to higher levels of uptake. An example is the role of primary care in UK colorectal cancer screening. I was involved in an evaluation of the pilot program of screening. This is a typical NHS top-down centralised program. GPs are quite peripheral. All the tests come centrally, all the results, whilst copies are given to GPs, they're all collated and responded to centrally as well, and all the follow-up is arranged. Yet we know that there are disparities in uptake. We know that primary care can reduce inequalities in screening uptake by addressing hard-to-reach groups. And many of the current strategies that the bowel cancer screening program is currently looking at to improve uptake do in fact involve primary care. This is just one example of a randomised controlled trial which demonstrates that a simple letter, just a simple endorsement from a GP can make a big difference to an invitation for a colorectal cancer screening test. Otherwise, these tests arrive anonymously with NHS letterhead. People don't feel they feel it's a bit disconnected from the process, and this simple process of endorsing it, perhaps signing the cover letter or using even the GP practice letterhead, can make a big difference to uptake. Of course, GP time is costly, and GPs, particularly in the UK, I've got I can't really speak for Australian GPs anymore, but if they are going to get involved, that involvement is typically linked to payments. So if we're designing interventions, they need to be not too burdensome, I guess, in primary care. And there's also different kinds of endorsement, ranging from just a line in a standard letter saying your GP endorses this process to an actual personalised note or a use of the GP letterhead. These things, they sound mundane, but when it comes to running a program and trying to get people engaged in it, they really do make a difference. And I think, as programs evolve around the world, this whole concept of GP and primary care endorsement needs to be incorporated in strategies, not just to promote uptake, but to promote informed choice and to reduce inequalities. In our work with GPs, we've found a range of responses to cancer screening. There are some enthusiasts, some completely ignorant about it, some are fully engaged in the process, some really resent it. And I've had some conversations with people involved in the bowel cancer screening program here in Australia while I've been here, people such as Graham Young, who've talked about GPs, some GPs who feel that this should be a primary care-led service. Why is the government taking over this important aspect of healthcare? So we get a whole gamut of different attitudes. But we know that, and I've mentioned most of these strategies now, that primary care can make a big difference. They can act as local champions in raising awareness in their community. They can endorse invitations, and there's a lot that they can do within their practices to promote screening. This is just a couple of quotes from some qualitative work we did in the UK on the bowel cancer screening program, and I think well, a couple of interesting things. The second one about partners hassling people, particularly wives hassling their husbands to take tests. I think that probably resonates with a lot of other programs. But this third quote about this disconnect, I suppose, with the organisers of the program and feeling that it's a fairly anonymous process and they'd feel more comfortable if their GP was involved, I think is important. We also did some work amongst hard-to-reach groups, and we had low response rates in our South Asian population, and that uncovered a lot of interesting sort of social and cultural beliefs about cancer and about screening. There is some quite good evidence that primary care is well placed to address some of those social and cultural issues. We know that the program has a potential to have quite a significant impact on primary care. Hence, it's important that primary care engages with it. Okay, so moving on from primary prevention and screening to early diagnosis. And over the last several years, there's been a real explosion of interest, I think, in how we can try and address this issue of late presentation in cancer, because we know that in a lot of cases people don't respond effectively to their potentially difficult or harmful symptoms. We know that in some cases GPs don't respond effectively when these patients present in primary care. So what sort of things can we do about that? Again, I showed these data earlier today, but just to illustrate how difficult it is to diagnose cancer in primary care and general practice, we typically only diagnose a handful of patients per year. If you look at the sorts of symptoms that people present with to diagnose those cancers, they're symptoms such as chronic cough or a slight change in cough, perhaps abdominal pain or some urinary symptoms. And these are symptoms that GPs just see all the time, every day, and somehow they've got to pick out those 7 or 8 cancers and diagnose them in a timely sort of way, so they have to sort of discriminate all of these symptoms. In the UK, or in England, in response to partly the less than favourable survival data and a strong suggestion that it may be due to late diagnosis, this National Awareness and Early Diagnosis Initiative was launched about 4 years ago, and it has, I guess, 4 key elements. First of all, there are strategies targeting the public to try and raise awareness and educate people about the symptoms of cancer, try and remove some of the barriers to earlier presentation, try and encourage more people to take up screening tests. So that's one element of it. Secondly, it's looking at what it can do for primary care. How can we raise awareness amongst GPs? How can we get GPs to recognise cancer symptoms and undertake referrals more effectively? And other issues such as improving GP access to diagnostics, because in this country it's quite easy for GPs to order investigations such as colonoscopies and CT scans and MRI scans, but in the UK that's much less accessible, and it may be that that's what's hindering things in the UK, that GPs just don't have access to those tests. And it's been supported by a strong sort of research and evaluation program. So this is just to summarise that. It's targeting the public in terms of increasing their awareness, trying to promote earlier presentation and uptake. It's targeting primary care to try and bring about more effective referral to secondary care, and also secondary care in terms of promoting early diagnosis, and a range of interventions, behavioural and system, which I'll mention a couple of those in just a moment. There have been some major surveys done in the UK to try and get some data on this issue. The College of GPs has done a major audit of cancer diagnoses. The National Cancer Intelligence Network has done this Routes to Diagnosis project, looking at patients' attendances in inpatients and outpatients and screening. There's also been a National Cancer Patient Survey. I'm not sure if anything like that's been undertaken in Australia, where patients have been able to report their experiences. And there's also, as I've mentioned, this International Cancer Benchmarking Partnership. This is some of the work on patient awareness and attitudes, and I found a couple of these responses quite interesting. This is over a third of the population in the UK anyway. When they're talking about barriers to coming to the doctor, they're worried about wasting the doctor's time. And this afternoon we had a discussion about whether that that same phenomenon would happen in Australia. I'm quite sure it would. Other people are worried about what the doctor might find. Other people are just too busy or even too embarrassed to present with symptoms. So these are the kinds of barriers to early diagnosis that this public communication campaign is trying to address. It tackles people's fear of cancer and to get at some of these unhelpful attitudes about visiting their GP. These are some of the promotional materials that have been used. It's been quite an active and aggressive campaign. It's worked on region by region and trying to, I suppose, get out messages that people can readily engage with and using language that people hopefully feel they can relate to. There's been a lot of controversy about using words like poo. I mean, is that condescending? Is it offensive or whatever? And as you can see, they're quite simple messages. But the designers of the program felt, well, if we are going to meet those barriers head on, we need to be giving out pretty simple and direct sort of messages. And it has produced an impact in primary care. It's also produced an impact it's raised awareness in the target populations. But if one looks at the three most relevant read codes, now these are codes for particular types of symptoms. So for the lung cancer campaign, we'd be looking at people presenting with respiratory symptoms. For lung cancer, a 23% increase over the following period of time in practices in that region, and for bowel cancer, over 50% increase. So that we know that those sorts of campaigns at least can make a difference in terms of people presenting to their doctors. This program has also had a major focus, as I said, on supporting primary care. A range of strategies have been used, including practice visits, using risk assessment tools, doing some audits and improving access to diagnostics. Some of these data are interesting in that if one looks at the diagnostic interval for cancer in primary care, it's less than 2 months for about 3/4 of the patients. So that's possibly not too bad. I suppose that it's the remaining 25% that we need to be concerned about. And similar sort of data for the intervals in secondary care. But about 3/4 of patients get referred after 2 or less visits. This shows the number of visits that people took to their GP before they actually got referred to hospital. So these are the numbers of people who saw their GP no more than twice before they were referred to hospital. So you can see that for breast cancer, where the symptoms are pretty straightforward, the majority of people didn't see their GP more than twice. But let's say for a rarer condition such as sarcoma, where the symptoms can mimic all kinds of other conditions, they're difficult to attach to a cancer diagnosis. They tended to see their GP more often. So these sort of data suggest that we need to focus our efforts on those cancers where the symptoms, I guess, are not so straightforward. You won't be able to see this. I just wanted to demonstrate, though, a GP practice profile. This is what's been happening in a lot of English practices. They've been given data on their cancer detection rates, on their referral rates, on the numbers of cancers that have been diagnosed as a result of their referring, their cancer screening rates, and their practices plotted against these averages for their primary care trust. And that's been found to be a very effective and acceptable way to change GP behaviour in this area. Also, there's been a piloting of these cancer risk assessment tools. These are tools which help GPs to make some sort of sense of patients' symptoms and come up with an actual score of their risk of having cancer on the basis of those symptoms. And it helps. It's a sort of diagnostic or referral aid, if you like. And those with higher risk scores they're more likely to be investigated, and doctors often report these risk assessment tools are just helpful in making some of these complex decisions around diagnosis, referral and diagnosis. Probably they lower GP's threshold for investigating cancer. And some early work on access to investigations would suggest that, at least in the UK, that rapid access would change GP's management at about 6% of cases. And just to, I suppose, underline the issue of access to investigations, colonoscopy, which can be used as either an investigation for following up patients with symptoms or positive fecal occult blood tests, but can also be used as a primary screening tool. But certainly, if one looks at the rates of colonoscopy in countries such as Australia compared to England, they're much higher, so reflecting, I guess, just a greater availability of those kinds of investigations in this country. So all of this information has been rolled up into this so-called toolkit for general practice, and that's been widely promoted in the UK. Looking finally at management and survivorship. If one thinks about the acute management of cancer, whether it's bowel cancer, lung cancer, breast cancer, generally in that acute management phase, GPs don't have a great deal of involvement. They might get involved in one of the initial multidisciplinary team meetings, but more often than not they aren't. There's, I guess, generally a sense that that's a phase of the journey where GPs in primary care is left out. But if you look at rates of consultation in primary care during that active treatment phase, what do you find? Well, an substantial increase compared to patients without cancer in face-to-face contacts, in prescriptions and referrals, consulting and prescribing relating to psychosocial issues. And this finding has been repeated over and over again with different kinds of cancer. So whilst primary care may not have a formal role in that active treatment phase, we know that these patients are still seeing their GPs and some kind of active management is going on. More often than not, though, we talk about the role of primary care in follow-up, and this has a range of there's a number of reasons that we conduct follow-up for cancer patients. We're interested in detecting recurrence, looking at side effects, promoting quality of life, and so forth. if we look at the evidence for where this sort of follow-up should happen, there's been some good randomised controlled trials now, particularly in breast cancer, which suggest that primary care can provide this kind of follow-up equally well, just as well as secondary care. This was a study by Eva Grunfeld, where she randomly allocated women who'd been treated for breast cancer to either follow up from their GP or their specialists, and on a range of important outcomes, including time to diagnosis of recurrence, cost, quality of life. There was really no difference between those two groups, but a substantially lesser cost and more time actually spent with the patient. She repeated this work in Ontario, a similar sort of design, and again found that on a range of outcomes such as recurrence, serious clinical events such as spinal cord compression, there was no significant difference between groups who were followed up by their family physician or in hospital. So the evidence would suggest that primary care-based follow-up of cancer patients is equally or even more effective. In Australia, there are almost 150,000 women living with breast cancer, many of them on long-term follow-up regimes in specialist centres. The Cancer Australia has recently completed a shared care demonstration project, which has allocated over 1,000 women in 5 different centres to receive a package of shared care between GPs and specialists. And these are the sorts of things that you would expect to happen in a basic sort of breast cancer follow-up protocol, in addition to psychosocial support. And in this project, it's been demonstrated quite clearly that both GPs and specialists, and also the patients, find this kind of approach acceptable, and it, I think, augurs well for future rollout of this kind of model of cancer follow-up. And this is just an example of the shared care plan that was used in that study. It was carried around by the patient and signed up to by both GPs and specialists. A range of strategies were used to engage GPs with that study, including using educational approaches and even getting patients to approach their GP themselves, and pretty high uptake rates, and also some documented compliance with existing clinical guidelines for follow-up. If one looks at the evidence, do primary care doctors want to do follow-up care? Several studies have looked at this, and on the whole, they are keen to take on a greater role. If you ask patients, you get a more mixed view. And a study I did way back with Kelly McGorn, who's at the back, on hospital versus GP follow-up for colorectal cancer patients, found that a lot of those patients actually didn't feel comfortable about getting sent off to their GP. This study a few years ago found that a lot of breast cancer patients prefer specialist follow-up. So if we are going to go down this route, there's quite a sort of an educational task to be undertaken. I I've been involved in some systematic reviews on this issue, and I guess the conclusions that we've come to are that primary care-based follow-up can lead to better health outcomes. It's well placed to address some of these chronic and complex needs that these patients have. Many GPs do want to have a greater role, but there are some caveats, and many cancer patients, as I said, do prefer to stay more closely linked in with hospitals. And some problems do require more specialised skills. The final point, I think, is important because we must never make the assumption that primary care is always in a position to take on these sorts of extra tasks, and we know that the quality of primary care and the capacity to take on these sorts of roles varies a great deal. Finally, on survivorship, there's a strong focus on survivorship in this country and around the world. Australia, looking at all cancers combined, has this growing cohort of cancer survivors. We also have a growing number of centres of survivorship care. This is one study which looked at how GPs can get more involved in sort of follow-up and survivorship in the UK, and it looked at quality and outcome indicators. Now these are indicators which are used in the UK to reward GPs. Unfortunately, the bottom line hasn't come out here, but this line refers to cardiovascular disease. This is smoking, and this is cancer, and this is the number of indicators that we have to reward activity in cardiovascular disease, and this is the number that we have for cancer. So one of the big problems that we face, I think, in trying to reward GPs to get involved is that we don't have the appropriate ways to measure what we're actually doing in primary care. A lot of interest at the moment in survivorship care plans. They can contain important guidelines and educational information. So far, not convincing evidence that survivorship care plans work. This recent RCT wasn't able to demonstrate a beneficial effect, but I think we need more research in this area. And finally, there's a lot of focus at the moment, I think, on trying to risk stratify patients who are undergoing follow-up care, and to try and identify those who can perhaps get by with self-care or minimal support, those who might need perhaps a shared care approach, and those whose needs are going to be complex. Okay, so I'll just skip through that pilot study on survivorship, and just to again emphasise that there is a huge shift in the way that we're thinking about cancer in Australia and elsewhere, and a growth in centres promoting survivorship. So finally, just to talk a little bit about policy. There's typically been a bit of a divide, I think, between policy and researchers. So these people are asking, where are they? You're 30 metres above the ground in a balloon. You must be a researcher. How did you know? It's correct, but completely useless. You must be a policy maker. Yes. Because you don't know where you are, you don't know where you're going, and how you're blaming me. So I guess this highlights the disconnect that can sometimes exist between those of us in research and those who are trying to put research into practice. If you look at the way that research evidence has translated into practice in important areas in cancer, such as the kinds of modalities that we use, the target groups, the way that programs are organised, how we organise follow-up strategies. There's been a huge variation, I suppose, in the way that evidence has been interpreted and implemented around the world, and I think that's an ongoing challenge for us. Of course, evidence-based policy making doesn't happen without good evidence in the first place, and just a quick plug for the PC4, the Primary Care Collaborative Cancer Clinical Trials Group. That's a group which John Emery leads, doing a lot of relevant research here in Australia on primary care and cancer. So conclusions. What I've tried to get across, I suppose, is that in cancer, primary care has typically had a recognised role in assessing symptoms, perhaps doing some delivery of screening programs, and the role in palliative care. But we've been excluded, I think, from other aspects of the cancer journey, and I think that is slowly changing and needs to change at a greater pace. I think there have been reasons for that, this perception that cancer is a high technology and hospital-based problem. There are territorial issues and so forth. I think that needs to change. I think primary care can have a broad-based contribution, whether it's about promoting awareness of cancer symptoms, whether it's about coordinating care for patients with complex needs, whether it's around primary prevention. And primary care tends to be more affordable. I think it needs to find its way more into national cancer plans, building on these strategies around primary prevention, screening, and early diagnosis. I'd like to acknowledge my collaborators, NCRI in the UK, PC4, Cancer Australia, the UNSW, where I'm based at the moment, and again the Australian Primary Healthcare Research Institute for funding this fellowship. Thank you very much for your attention.
This is a rehearsal.
Right, okay. Oh, you didn't tell me in advance, actually.
We're all colleagues from Commonwealth.
So you need to speak. I'm sorry, we
Yep.
don't have a microphone this evening, so
Okay, I'll speak up.
if you could speak up.
Yeah.
Yeah, thanks.
My name is John Scott. I'm the co-chair of the Renal Advisory Group in town. I'm a transplant patient, long-standing, and all of those impediments to primary care involvement I happen to agree with. There's real stigmatism about whether primary care is actually capable of coping with these things. I'd like to suggest that we actually take the role of primary care and put it in a different context. Part of the real problem for specialists is that they actually have no access to much of the information they need in order to carry out their bit of work. And that has to do a lot of times with medications. It has to do with all of the other things that I and other patients have. And what we're starting to explore around renal services here in the ACT is how do we engage effectively with GPs, but also with the other specialties, so that we can actually start to say, well, what's really important in actually being effective, safe, high quality, and efficient is actually that information flows related to the knowledge of the patient on the basis that the information is meaningful, it's accurate, and it's trustworthy, and it's where you need it, when you need it, and the manner you need it.
Yep.
And for our part, we're about to introduce an electronic medical record system. It's not a medical record system per se. Its real focus is on communication, and we are purposefully crossing the boundaries, which in Australia are formidable, public-private, cross-border, but that is what we intend to do. But I would suggest that part of the problem we have here is that we continue to think in silos.
Yep.
Much of this presentation could be argued that this is a GP argument, right? And sitting back and watching this thing and saying, oh yeah, okay, here we go again, you know. And yet it is absolutely critical that we sort out how to work together.
Yep.
and to understand where leadership needs to be exercised and how
Yes.
we toss the baton back and forth effectively.
Yeah, no, I agree with all that you say, and it's an argument for a better sort of brokerage of information, because we've still not cracked that nut. We don't know how to bring in effective, for example, patient-held medical records. There's not really, with perhaps the exception of one or two health maintenance organisations in the US, where they have got some not bad information systems. We haven't really ever developed a good national system in countries like Australia or the UK for electronic health records. And your point about integration is exactly right. I referred to a couple of trials of GP versus hospital follow-up, and I'd actually argue that those trials in today's context would actually be quite helpful, because you're right, we shouldn't be thinking about that, thinking of things in that way. We should be doing demonstration projects on integrated care, where we don't just say that patients are either looked after by their GP or looked after by their specialists, that it's all sort of joined up a great deal more effectively.
Yep.
Hi, I'm a GP in Melbourne, but I'm here for an invitation of my friend Robert. I trained in Britain as a GP, and I was working for 20 years. There's a few observations I would make. One is I'm quite stunned that despite a patient having a practice and having a lot of information in GP systems in the UK for computers came in 25 years ago, it's some gusto, and we need to develop at that stage. But that's actually the cure rates or the survival rates so much less, especially with the injection of Blair money and so on in between, and the cancer centres we put in and the rapid movement. So there's lots of lessons for us. We think we're doing things very bad in Australia.
Yeah.
Because they actually we've got a pretty good system how to make it better. And how do we look what we do.
Yeah.
As a GP working in the system, one thing that I've benefited from for 25 years is being able to use my brain and actually investigate people with the access to services we have here, that we don't have to refer everybody to hospitals, Royal or wherever, Western General, Edinburgh.
Yes, sure.
Because you can't do it yourself. So
Yeah.
to me, there are many of those things that are there. And my colleague here was, thank you for finding the flag for electronic health records. My little forays in this area.
Yes,
It's not going to be perfect, but the more information you have to share, the better care is going to be.
I think, examining those survival differences raises a whole lot more questions than you could ever possibly answer. And the answers may differ by cancer. There's some recent work that's come out on looking at the differences in ovarian cancer survival. And that actually suggests that late presentation is a factor, but it could be access to appropriate and high technology treatment services that's helping you to underscore that. The other thing, I suppose, about if you were looking at those data from an Australian or Swedish perspective, and John might want to comment on this, is it does mask within country differences. So there's clearly, no country has any cause for complacency, but clearly there are disparities still between, there are socioeconomic gradients in survival, there are disparities according to ethnic subgroup and according to whether indigenous populations or white populations and so forth.
John Emery is the Professor of General Practice at the University of Western Australia.
Yeah, I think you're right. There is no room for complacency, even though Australia looks remarkably good on those international benchmarking exercises. There are very large inequities in cancer survival, particularly in more remote that you get. There's a gradient of survival the further you get away from the city. And then, as you say, within socioeconomic groups and with cultural diverse group. So those differences in survival within a nation get very masked by that level, and also the differences between cancers as well. As you say, exactly what is underlying those international differences is very complex. I think access to diagnosis is one part of that, possibly later presentation, but I think access to treatments as well is probably much better in this country than in some of the other countries.
I think I have to speak on behalf of the Department of Health maybe, but I just want to say that we've done some quite complex analysis, and I'll make 3 comments. One is, yes, there is variations, and it does follow the social gradient, and it does follow inequalities, and indeed all the different socio-demographic groups as one might expect. But broadly, one of the if you look at the attributions and sort of explaining the variance, then we certainly believe that the better survival rates, they do vary by tumour, but basically it's that universal healthcare insurance system that we have in this country, and it's about public hospitals and access. And when you look at that variation, in fact, that almost explains all of what you've got. And I personally think that explains a lot of the difference in terms of survival rates. But the other things that we've got is some very robust infrastructure around cancer registries. It allows us to monitor and track much more efficiently and effectively than a lot of other places. And we have, we've got we've got sort of world-class rates in cervical screening and so on because of the reminder type systems. But we've also got access to follow-up, and we don't have that wait time. When we look at that wait time, it's completely different from the wait time in Europe. So I think there's some structural health system type effects which explain a large part of that variance.
Yeah, I mean, I think the disappointing thing in...
but we can still make a lot of improvement.
Sure. The disappointing thing with the UK was that there was a really substantial investment in the NHS over those 10 years. Lots of dedicated cancer centres. There's universal healthcare in England as well. The treatments are all there. You know, perhaps they may be a bit less accessible, but I suppose one of the factors which could be explaining the differences would be the way that primary care deals with those symptoms and makes its referrals and diagnoses.
And Diacon's work from New South Wales shows that it's about the different tumour types. When you look at it, it's hugely different.
Yes.
Look, I think one last question from Harish.
Harish Dowd, I'm a GP and I negotiate training in the UK and recently come to Australia. I wanted to ask a question focusing on the prevention bit really, and your presentation focused mostly on primary care and general practice and GPs. I wondered what your thoughts were on the role of pharmacists, for example, in prevention and smoking cessation.
Yeah. Look, I think we've got to take a broad brush to prevention and use every opportunity. And if you take the broadest definition of primary care, pharmacists provide a huge amount of primary care, and they're very well placed to do good interventions, not just when people come in for their Nicorette prescriptions, but in a whole range of different ways, and some good evidence in the literature now that pharmacists can have a role. Similarly, within primary care, I think a lot of primary prevention advice can be delivered by practice nurses, probably as effectively or more effectively than by the GP, just as they can deliver a lot of chronic disease management more effectively than we can. So, I think you need to keep a pretty open mind.